Why do clinical scientists make mistakes between COPD and asthma?
Well, that is a common issue and problem in the diagnosis of patients with asthma who have smoked. The symptoms can be very similar, lung function impairment can be very similar, but of course the treatment that is required to treating either can be very different. So it is important to separate this, but on individual cases, especially patients with mild asthma who have smoked a lot, it is very difficult sometimes to separate which is the important component and which treatment the patient should receive. And you do find patients who have smoked many years but do not have a COPD, but actually asthma is their problem. But because they have smoked a lot, often doctors think that this is COPD instead of considering asthma. So it's a difficult differential diagnosis, especially in elder patients and in patients who have smoked a lot.
Which is the role of phenotypes in a correct diagnosis of COPD?
Well, based on the individual treatments that we have available now for asthma, that includes biologics. For COPD, the question remains whether inhaled corticosteroids should be used or not. It is very important to identify phenotypes in asthma as well as COPD, because the treatment that is suggested for these patients differs, and the right patient should be receiving the right patient. And this is increasingly based on so-called phenotypes.
Are the biologics useful in preventing COPD exacerbation?
Well, the only biologics that have so far been used in COPD are anti-interleukin-5 treatments in so-called eosinophilic COPD. I'm very convinced that those patients who responded to the treatment, as is nicely shown in the literature, are those with a high eosinophil count, and my prejudice would be that these patients in fact did not have COPD, but in fact have asthma and were probably misdiagnosed, which can happen to even experts in the field. The studies that looked at biologics in COPD have been, and I think this is the interpretation of all the studies, been negative, and I don't see any role for anti-interleukin-5 treatment in the treatment of COPD.